Hi, this is Kathleen. This is the musculoskeletal system. Here's your objectives. Mostly we are going to be concerned not so much with describing the function of bones and muscles, because that's going to be things that you cover in anatomy and physiology. We're going to look at age-related changes, subjective, objective data, and physical assessment. Here's the functions of the bones. Key concept for the musculoskeletal system is mobility. The assessment is going to focus on mechanisms that aid or impair mobility. And we're also going to consider, keep in the back of your mind, concepts of oxygenation, perfusion, tactile perception, pain. Each factor contributes to mobility. Going over the bones, here's your axial and appendicular skeleton. Articulations, synovial joints, ligaments. Ligaments are strong, dense, flexible bands of connective tissue that hold bones to bones, and they allow some movement and restrict other movements. Tendons are strong, non-elastic cords of collagen, and they're located at the ends of muscles, attaching them to bones. Tendons support bone movement in response to skeletal muscle contraction. Skull and neck. 6 cranial bones are fused together, and you know that the face consists of 14 bones. Neck is supported by the cervical vertebrae. Neck is also supported by the sternocleidomastoid muscle, and the trapezius links the scapula. Trunk formed by vertebrae, ribs, and sternum. The spine has 7 cervical, 12 thoracic, 5 lumbar, and 5 sacral. And you probably have already been told that the good way to remember that is the times for classic meal times: 7 a.m., 12 noon, 5 p.m. So 7 cervical, 12 thoracic, 5 lumbar. And then you can just remember 5 sacral. Here's bone structure, spine and vertebrae, muscles of the pelvis and trunk, and your appendicular skeleton and the supporting structures. Elbow joints, hand joints, wrist joints, and muscles of the arms. Appendicular skeleton and supporting structures, upper extremities in the hand, hip and thigh. And again, these are just review. Going through to the ankle and to the foot. Bones of the feet and the legs, muscles of the feet and the leg. And here is the hip joint. For patients that come in with a complaint, or you are just assessing them for musculoskeletal issues, you're going to ask them about chronic diseases, medications, what are they taking and how often. Remember that PPIs, proton pump inhibitors, can cause fractures in the elderly, particularly the wrist and the spine. And you also want to ask about corticosteroids and chronic long-term use. Corticosteroids like prednisone can contribute to bone loss. You want to ask about changes in movement, changes in what they can do during the day, accidents or trauma, and any surgeries on bones or joints. You want to ask about history of curvature of the spine in the family, any problems, history of arthritis, rheumatoid arthritis, or gout. Ask about exercise and how often, how many times a week, a month, a year do they exercise, what type of exercise, and how strenuously do they go. Are they able to talk while they're exercising, or can they carry on a conversation, Or can they completely not talk at all? They're kind of short of breath. That will tell you how strenuous they exercise. You want to ask what type of work they do. Think about what we do. Do we lift? Do we push? Do we pull? We do all of that as nurses, stooping. So all of those things. Consider if they have to carry anything heavy, like a letter carrier. And you want to know, how do they protect themselves? A lot of people will wear the lumbar support. So you want to ask about that, and do they wear it? For problems, PQRST, and you want to know, have them point with one finger. Where is the pain? Where's most of it? Does it go anywhere? Does it go from foot to ankle or knee to ankle, wrist to elbow? Anything make it worse? And how do you relieve it? You want to ask, how long has this been noticed? Do they ever feel like the joints feel hot? Ask about sore throats too. We also want to consider about bacterial or a viral infection. Muscle weakness. Are they able to do things and then at the end of the day it gets worse? Or even just shortly after they do things, they feel weakness. Have they ever felt like their knees or ankles were going to give away? How about going up and down steps or standing from a chair? Do their joints lock up? Ask about limitations and to what degree, and have them describe what they were able to do and how they can't do it anymore. When we examine for musculoskeletal, we do cephalocaudal, head to tail, cephalo being head, caudal being tail. So for us, head to toe. You always compare one side to the other. If you're looking at the right arm, look at the left arm. Right shoulder, left shoulder, and so on. You want to observe their gait. Have them walk. When you're doing your head to toes, have the person walk into the room, observe the gait. Are they favoring one side? Are their toes pointed forward, pointed out toward the walls, or pointed inward? You want to see if they're swinging their arms or their arms are tightly at their sides. Look at their face and the neck, and also palpate the jaw, the temporomandibular joint. You want to see if there's any clicks, any movements, any sounds, any tenderness. See if they can move the jaw in different directions, any pain when they move it. Palpate their neck and observe the neck for range of motion, turning right, left, looking up, down, and test for strength. Inspect the shoulders and the spine for alignment, and you want to see if they can bend down, touch their toes. Many people have lost flexibility even at younger ages, so see how far they can go down. Check the posterior neck, spinal processes. Spine should be straight and non-tender. Check the shoulders. Palpate the shoulders for firmness, tenderness, masses. Test the trapezius muscles for strength. They should be able to shrug up against you, pushing down. Observe the shoulders for range of motion. When you're testing the arms for muscle strength, have them push against you, have them pull back. Check the elbows for tenderness, edema, nodules, and range of motion. A lot of times this is where there is some tenderness. All the joints should be inspected, wrists, hands, elbows, and again, testing for muscle strength. Check the hips for symmetry and palpate the hips for stability and tenderness. The patient should be able to lie flat, sit up to a 90-degree angle, 45-degree angle, so the external hip rotation from a straight midline position moving forward. You want to test the hips for muscle strength, have them lie supine, and they should be able to raise their leg and overcome resistance. Have them extend the leg from the sitting position, and they should be able to maintain that extension, and they should be able to bend their knee. Check the medial and lateral aspects of the tibiofemoral joint space, and it should be non-edematous and tender. Popliteal space should be smooth and non-tender. Check the ankles, feet. Also, again, number of toes on the, if there was any injury to, or were they born without all 5 toes. Palpate the ankles and feet. When you get to children, differences for infants and children, the infant's movement would be assessed during voluntary movement. Hip joints are assessed for, and feet also, for abnormalities. You're looking for dislocation of the hip, club feet. And for children, you want to check their motor development and check it against standardized tables. This image did not come out. I'm not sure why it did not come out. It has previously. This image is also, there is in your book, Wilson, page 423, and you are going to see the Ortolani maneuver. There's 2 maneuvers, Barlow's and Ortolani's. Ortolani's is down and out, and this should be tested on the infant every visit until the infant is 1 year old. There's also another test, Alice test, ALLIS, and it's also for hip dislocation. So a positive, any one of these tests, Barlow, Ortolani, or Alice, indicate hip instability. You also want to look at skin folds. If they're uneven, that's another sign that says there is probably a hip dislocation. Check out their hands, look at the shape, looking at the hand, the palm for a palmar crease. Palpate the length of the clavicles. Clavicle bone is the most commonly fractured bone during birth. And then populations at risk for hip dislocation. Navajo Indians and Canadian Eskimos are among the highest groups at risk. There's more incidence of the hip dislocation in the infants, and the cause is attributed to the tightly wrapped in blankets and strapped to cradle boards. So in cultures in which the infants are carried on their mother's backs or hips, hip dislocation is rare. And again, I apologize about this image too. This is children, preschool and school age. You want to put them and note their back posture. You should see a plumb line, so level. If you've ever worked with a level, you know that plumb means it's level. The plumb line from the back of the head along the spine to the middle of the sacrum. Shoulders should be level within about 1 centimeter. And then you also want to look at their legs, their feet for deformities. You want to look at bow legs, knock knees, flat foot, pigeon toe. We want to check arms for range of motion and any pain with that, and palpate the bones just like you would in an adult. For the older adult, the exam is the same, just may be slower at performing range of motion. It doesn't mean anything's abnormal. It just means they've slowed down. And also muscle strength may be less. Fractures. On your modules is also a PowerPoint of fractures. It goes into more detail, and the notes are included. This just is talking about fractures, what you're going to find, and there's an image on the next slide. A fracture is partial or complete break in the continuity of the bone. Sometimes it's really hard to see. Radiologist is trained to look for the smaller fractures or hairline fractures. Open fracture, easy to see. The key to this with fractures, especially fractures of the leg, but fractures of the arm or anything, immobilize. Don't get them up. Don't move them. Don't have them walk anywhere. Insist that they stay down. Osteoporosis, loss of bone density. We know that this happens with age. And it occurs with people don't even recognize that it's happening. And after a certain age, men and women are measured when they come in. We want to see how much height they've lost. And we also want to check curvature of the spine. This image shows the curvature. So the person at age 40 was about 5'6", and now at age 70, they're just maybe about 5'1", 5'1.5". This person has the hallmark of osteoporosis, and you see that there. It's called a dowager's hump. It's kyphosis, so they're bending in. And sometimes a more severe kyphosis can affect the neck and also even respiratory status. Rheumatoid arthritis, this is chronic, it's autoimmune. We have about 1.5 million people in the United States that report a history of rheumatoid arthritis. So their symptoms are pain, edema, stiffness of fingers, wrists, ankles, feet, and knees. So all the joints. They complain of it most in the AM, and sometimes it takes up to a half hour or even longer until the stiffness goes away and the pain. They also will complain of ulnar deviation, swan neck deformity, and boutonniere deformity. You can see that on figure 14-29, and you can also see it here on the slide. This on the slide is boutonniere deformity. So osteoarthritis is degenerative changes, and joints are affected with repetitive motion, stiffness. People will complain of. Keep moving is the key. Keep moving. Encourage people to keep going. A lot of times people will find that they feel more comfortable doing exercise in a pool. Hopefully it's a heated pool, and walking in there as often helps the joints. Gout, it's hereditary. It's an increase in uric acid. So there's an increased production. They need to have uric acid level. And it's thought to be caused by a lack of an enzyme needed to completely metabolize purine. So you want to assess the diet for purines. Uric acid can form crystals that cause kidney stones, and these would be examined. So of course with the kidney stones you want to get the crystals and have them examined, and then teach the people about low purine diets. Scoliosis, that classic S-shaped deformity, so uneven shoulders and hip levels. Some people have about 10%, and that's considered mild. But they can have a rotational deformity that causes that hump and flank asymmetry. This rotation can cause, depending on how severe it is, it can cause physiologic dysfunction of the lungs, the spine, and even the pelvis. And here is what the person looks like. You have them bend over, and you can see that scoliotic spine. Carpal tunnel syndrome, it's medium nerve compresses on the flexor or the carpal ligament, and it's usually from repetitive motion, so typing. We also see it now more commonly in teens from texting and that quick thumb movement, so they are being examined for carpal tunnel. Two of the ways that we assess for this are Phelan's sign or Tinel's sign. Phelan's, they have the hands back to back, and they will have some numbness or tingling during that, or some pain. And the Tinel's test, you can see there too, and they would also have the numbness and tingling. The next slide, on my copy here, you cannot see the image. So the question is, the nurse assesses the patient and notes that image and what would be the accurate assessment. And this image would be an ulnar deviation, which I do have images of that I can show you. Question number 2, this person requires they have the patient doing multiple exercises to identify the health status, and they want to test the trapezius muscle. And how do they do that? The correct answer would be A. They're going to shrug the shoulders against resistance. Here's his subjective complaints. Right great toe. What do you think that is? What kind of pain? He's got some unsteady gait. It's the second attack he had this year, and the pain from the right great toe seems to go to the right ankle. Here's your objective data, and looking at the toe, it's red and swollen and a little bit of edema. Obviously, if you said gout, you were right. What risk factors does this patient have? What measures might have prevented? So his risk factors are high seafood consumption, history of hypertension, and previous gout attack. So this person needs teaching regarding low purine diet. So provide them with a list, have them go over it with you. Family needs to be involved in this too. So they need to make these dietary changes a lifestyle change. They need to have uric acid looked at, so obtain an order for that. Review their current diet, have them write down, keep a diet journal maybe for a week and look over what they eat. Talk about previous attacks, and you want to talk about medication, particularly their hypertensive medication. How are they taking it? Are they taking it at the correct times? And are they monitoring their blood pressure? Along with this, you want to consider having an order for a CBC to follow up on this. You want to look for any problems there. Thanks. Have a great night. We have a quick case study. We have a 60-year-old male postal worker. He works all the time. He eats seafood and beef platters, and he has a history of hypertension and COPD.